This is more of a talk with cases involved. The literature surrounding the lumbosacral junction is much more profound and diverse and very thorough. When looking at the cervical thoracic junction, the literature is actually very, very sparse, with mostly focusing on perioperative outcomes. So the issues with complications of long fusions into the thoracic spine, I believe the ones that we deal with outside of that fall into the highlighted yellow categories of alignment and balance, adjacent segment degeneration, pseudoarthrosis, and instrumentation or fixation-related failures. And when we have poor techniques, we can all look at this and see a progression of mistakes being made repeatedly, that we take our patients who come in like this and send them out less beautiful. And that's not acceptable here in Brazil. So remember that the majority of all of these things we're talking about is 90-something% multi-level spondylosis with or without myelopathy, and those other deformities really fall into very minimal and rare categories. Now those patients, however, I think provide significant difficulties with just assessment, because we expect them to have pain due to the arthritis, the deformity, or the soft tissue issues. We expect them to have neurologic issues that are either permanent or not. And the pain generators are still present with these patients. They have muscles that can't move. We have unfused discs. So the transition of the cervical thoracic junction has specific anatomic considerations that we're all very well aware of, where in trauma we see a focus on that junction from the flexible to the rigid. And the biomechanics, multiple studies again show how that rigidity increases descending. Another major issue with cervical thoracic junction is fixation points and types. There are more fixation points, obviously, than the lumbosacral junction, with good rigidity and better than probably within the cervical spine itself. So issues of alignment, this is obviously an increasing topic, but when I look at alignment parameters, I think that it's not just sagittal and coronal. We need to look at the global fixation that we put patients into, and this involves regional lordosis, but regional lordosis with respects to the global balance, and as well as those transitional considerations, and then segmentally, what are we doing to patients, and are we creating these problems themselves? So global alignment parameters, this individual has great cervical lordosis, but in the greater scheme of her overall alignment, that is an issue. And the last thing that I think we don't focus on quite enough when we're dealing with people who are healing and fusing or trying to get a fusion over a period of time is, what is their proprioceptive presumption? Is PJK an issue because this patient wants to go back to their normal alignment and their cerebellar dysfunction does not allow it to achieve a fusion before that occurs? Are there any accountants here? Nobody's an accountant, then I don't know how we're supposed to judge this on every case, but I think there's been so much work on this plus or minus 9, etc. And I think it's simpler than that. I think we all have a presumption of subaxial alignment, and the literature is out there. Again, if we do our cases with restoration of lordosis, we can prevent a good percentage of these cases from ever needing to be extended to the cervical thoracic junction. And papers are now showing, much like with the SVA, that NDIs increase with dysfunction of the sagittal parameters. So look at this patient. They again have excellent global lordosis. They have excellent regional lordosis, but globally, that is not affected. We've not restored them to where they need to be. And we all know the outcomes of the weight-bearing axis of the spine when it's fused in malalignment. What happens when we extend it up? And so if you're going to do a procedure, this is one of my favorite patients. She's basically sending my children to college. But if you're going to fuse someone, you better get the alignment right, because you never know which the next surgery is going to be. And if anyone can find another surgery for her, let me know. So the cervical plumb line is something to also consider when. So with patients who are going to have or visually look like they have malalignment, I do think scoliosis X-rays and their alignment needs to be considered. So again, looking at C1 plumb line, and where does that fall relative to their overall balance? So SVA, again, I don't have the numbers to show you, but basically we're trying to prove that SVA is showing decreased NDI globally with multi-center studies, and this is something that has been very reproducible. So one of the main issues with whether or not to stop at C7 or T1, again, is going to be adjacent segment degeneration, and I used this slide on the last case. I'm not going to go over that, but we know that there's linear degeneration. And the other thing that we've seen is that it follows the lordotic curve anatomically of the spine. And that curve on the right demonstrates that your rigidity and your stability increases as you get to the cervical thoracic junction. And fusions to that junction have a low risk for AC, adjacent segment degeneration. This paper has since been published, but it's Dan Rue demonstrating that stopping at C7 over 4 or 5 segments, that there are significant reoperation rates and decreased outcomes scores with lower revision rates if you actually go to the cervical thoracic junction. This is an example I would demonstrate that stopped at C7, and I don't know why. I believe this is one of my partner's cases. We inherited a case that stopped at C7, and the overall global alignment is not restored. And quite frankly, I don't know if I've restored it with extension to the cervical thoracic junction there. The concern would be, well, what about pseudoarthrosis or instrumentation failure? And my case presentation later on actually will demonstrate it a little further. But basically, revision surgeries, deformity corrections, laminectomies across the cervical thoracic junction, and tobacco use have been well established as risk factors for the pseudoarthrosis. But overall, that does not happen that frequently. When we look at what type of instrumentation or techniques is it, well, I don't think anyone's willing to publish that their technique is not very good, and instruments themselves have not been able to show significant differences. This is a case which, again, is pretty neutral in alignment to slightly kyphotic. And without MRI imaging, I can demonstrate that this patient underwent very long laminectomy. She's quite myelopathic. And we went down into the cervical thoracic junction. But one of the considerations that is not always taken into account is what about that C7-T1 disc? And in our large series of 300 patients, this was the only one that went on to pseudoarthrosis, and I basically think that was because she had a high cervical thoracic junction and a very large disc, so there was breakdown across that. Again, is this proximal junctional kyphosis? Is this lack of fixation? Or does this mean that we need to also combine with an anterior approach? I have a low threshold for achieving stable fixation. Again, talking about most of these patients, they have neurologic concerns, and so I go long when I have to go long. And if that includes C2 to T2, then that's when I would. There's a case I'm going to show later, so I'm not going to get into that. And then this is, again, looking at our overall patients when it comes to approach, whether or not multi-level anterior across stopping at the cervical thoracic junction, you get better fusion anteriorly, and if you do long fusions that stop at C7, what is the adjacent segment degeneration rate, and how does that compare to posterior? And quite frankly, we did not see much of a difference. Overall, the reoperation rates are not that high. So in conclusion, I think these cases present some very, very scary and nasty looking x-rays. But we have a lot of weapons, front, back, extension or not, to combat them. And in the end, I think our patients, these are actually very good patients, I think, in the long term. So, thank you.